Hello, my name is Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today, I'm going to be discussing the management of recurrent vulvovaginal candidiasis, and I thought we'd start with a case study to set the scene. Beth is a 24-year-old lady. She comes to see you concerned that she has had 6 episodes of thrush in the last 8 months. She has managed these with a variety of over-the-counter treatments, including oral fluconazole and intravaginal clotrimazole pessaries. Whichever treatment she opted for alleviated her symptoms within a few days. She is, however, concerned with the frequency that the condition is returning, and neither acute treatment that she has used seems to keep it at bay. She finds the symptoms distressing and embarrassing, and she has had to miss several days of work, she's a newly qualified teacher, as she cannot manage the discomfort and itch while trying to teach. She wants to know why the thrush keeps coming back, and she would like you to prescribe something stronger than the over-the-counter treatments to get rid of it once and for all. I wonder if this story sounds familiar. It may well do, as unfortunately recurrent vulvovaginal candidiasis is not uncommon, with around 6% of women of reproductive age being affected by the condition. So throughout this podcast, we're going to discuss the risk factors for and investigation and management of recurrent vulvovaginal candidiasis. So, recurrent vulvovaginal candidiasis is defined as at least 4 episodes in 12 months, with 2 of these episodes confirmed by microscopy or culture. At least 1 should have been confirmed on culture. Candida yeasts are present in low numbers in areas of healthy, moist skin, but an overgrowth of Candida yeasts results in symptomatic infection, and recurrent candidiasis is thought to be related to host factors that allow this overgrowth to occur, rather than the person being infected with a more virulent strain of Candida. I think it's worth being aware that around 20% of women may be colonised with Candida during their reproductive years, and if there are no signs or symptoms, then this does not need to be treated. Risk factors for recurrence include poorly controlled diabetes and immunosuppression, and antibiotic therapy in the last 3 months that has disrupted the normal flora. Sexual intercourse is associated with recurrent infection in some women, but it is worth noting that vulvovaginal candidiasis is not a sexually transmitted infection, and the association with intercourse may be related to vaginal dryness. Recurrent infections also seem to be more common in high estrogen states, such as pregnancy, and there is also a possible association with HRT use and a weak link with combined oral contraceptive use. There have been reports of recurrent vulvovaginal candidiasis with the copper IUD and levonorgestrel intrauterine systems, possibly due to the Candida settling on the surface of these devices. In these instances, consideration would need to be given to decide whether to remove the device and find an alternative contraception, or retain the device and control the candidiasis with maintenance treatment. Atopic individuals appear to have a higher risk of recurrence, but interestingly it's not clear if this is due to the underlying atopy or their more frequent use of corticosteroids. Other risk factors have been suggested, such as lower cortisol levels because of chronic stress, iron deficiency anemia, vaginal douching and non-breathable clothing, but to date, the evidence behind these associations is limited. Examination of a patient with candidiasis may reveal evidence of scratching, non-offensive discharge, erythema, fissuring, swelling, and possible satellite lesions. Examination is an important step in the care of your patient, especially in recurrent candidiasis, as other conditions such as dermatitis, eczema, and lichen sclerosis can present with similar symptoms, and it's also possible that your patient may have dual pathology, with, for example, lichen sclerosis and candidiasis coexisting. Without an examination, you would not be aware of this, and this would have significant implications for the effectiveness of your attempts to treat your patient. So, what investigations are needed? Well, swabs to confirm the diagnosis are the most important investigation that we can undertake in primary care. And self-collected swabs are a reasonable alternative to clinician-taken swabs, if this is more acceptable or practicable. In terms of other investigations, it's worth asking about and examining for other recurrent infections that may prompt an investigation for immunodeficiency. Checking an HbA1c in case of undiagnosed or uncontrolled diabetes, and considering a full blood count and ferritin to look for iron deficiency anemia would also be sensible suggestions. STI testing is not universally required, and the appropriateness of suggesting STI testing will depend on the patient's level of risk and your level of concern about a possible alternative infection. So, for example, if your patient has had unprotected intercourse, a new sexual partner, or is experiencing malodorous or discoloured discharge, then this might be worth considering. So, how can we manage recurrent vulvovaginal candidiasis? Well, simple lifestyle advice, as we would give for any acute candidiasis infection, is still relevant. So, avoiding local irritants such as perfume soap or wet wipes. And it's worth reviewing the patient's daily hygiene regime to look for possible irritants that the patient may not have been aware of, such as excessive cleansing or soap or shampoo in the bath water. Patients should be encouraged to use emollient as a soap substitute, moisturiser, and barrier cream. And these emollients can provide symptom relief, especially as vulval dermatitis is commonly present. Sexual intercourse does not need to be avoided, but a patient may choose to abstain if there is fissuring or dyspareunia that makes intercourse uncomfortable. If sexual activity does seem to trigger symptoms, then a gentle water-based lubricant can be considered. Because of the weak association with non-breathable fabrics, panty liners, and vaginal douching, it is sensible to advise patients to avoid these. In addition to the lifestyle changes described, we also need to consider our treatment of the acute infection and possible prophylaxis to prevent recurrence. So, firstly, to treat the acute infection. Both the BASH and NICE guidelines agree that the first-line treatment for acute vulvovaginal candidiasis is a single dose of fluconazole 150 mg. If oral therapies are contraindicated, for example in pregnancy, risk of pregnancy or breastfeeding, or if they are not tolerated, then a single dose of a 500 mg intravaginal clotrimazole pessary is a safe and effective alternative. If the patient has vulval symptoms, then a topical imidazole can be added to oral or intravaginal treatments. It is worth noting that both intravaginal and topical treatments can damage latex condoms and diaphragms, and patients should be counselled regarding this to avoid the risk of unplanned pregnancies. All oral azoles and intravaginal imidazoles achieve cure rates in excess of 80%. They are equally effective and tolerable, with no difference in treatment outcomes. However, oral azoles can interact with other medications and can prolong the QT interval. So check the BNF for interactions and exercise caution if the patient has other risks for QT prolongation. For more severe disease, 2 doses of either oral fluconazole or intravaginal clotrimazole are recommended and should be prescribed for days 1 and 4 of treatment. This has been shown to improve symptom response, but it does not affect the risk or rate of recurrence. For recurrent vulvovaginal candidiasis, we're encouraged to prescribe an induction and then a maintenance regime. The first-line suggestions are for oral fluconazole 150 mg every 72 hours for 3 doses, and this achieves remission in up to 90% of cases, followed by fluconazole 150 mg weekly for 6 months as maintenance therapy. If this regime is contraindicated or not tolerated, then an alternative suggestion is to use topical imidazole therapy for 7 to 14 days according to response, and then for maintenance to either use a clotrimazole pessary weekly for 6 months or oral itraconazole 50 to 100 mg daily for 6 months. If the patient has a recurrence of the infection once maintenance has been completed, then assess how frequently these recurrences are occurring. If it is an infrequent recurrence, then treat each infection individually. But if frequent infections are occurring, repeat the induction and maintenance treatment already described. If the patient has a poor or partial response to treatment, then we need to consider why this might be happening. Do we have the correct diagnosis? Is there a dual pathology that has not been treated? Does the patient have a non-albicans candida species? Do they have azole resistance? In these situations, re-examining and re-swabbing would be recommended, and ask for species identification and sensitivity testing on the swab. A microbiological response but ongoing symptoms should prompt a reassessment for alternative causes. The NICE guidelines suggest referring women with non-albicans candida, azole resistance, or those with possible alternative or additional diagnoses to gynecology or GU medicine. For non-albicans candida and azole resistance, we find that they may be more effectively treated with intravaginal nystatin pessaries used nightly for 12 to 14 nights. An acute effective treatment in these situations may prevent recurrence and the need for ongoing maintenance therapy. If recurrence does occur, then this acute treatment can be followed by a maintenance regime of nystatin pessaries for 14 days every month for 6 months. Nystatin pessaries are the only licensed alternative to azole therapy. Interestingly, there is some evidence of benefit from prescribing cetirizine 10 mg daily for 6 months in patients who do not get a complete remission from their symptoms with maintenance fluconazole. And we can consider adding this to maintenance therapy, especially if there is a history of allergy or atopy, although it is worth noting that this is an off-label indication. It may also be worth looking for other reservoirs of infection. Is there candida infection on the digits or in the umbilicus, for example, that might be resulting in recontamination and needing treatment? The patient's partner may be the source if they also have symptomatic infection, and if this is the case, then treat them at the same time. There is either no evidence or insufficient evidence for the use of probiotics, orally or vaginally, tea tree or other essential oils, breathable underwear with antimicrobial protection, yogurt and honey mixes applied locally, or dietary changes, including oral garlic, in the management of recurrent vulvovaginal candidiasis, and these options are not routinely recommended. Finally, I would encourage you to explore and discuss psychosexual and emotional issues with patients with recurrent vulvovaginal candidiasis. It is a condition that can have a profoundly negative impact on a patient's quality of life that is comparable to asthma and migraine. In addition, low libido and reduced arousal are common in any chronic vulvovaginal condition, and patients might be very grateful to you for initiating this conversation. So thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. And we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.